Welcome to part 2 of the Royal Alex Children's Hospital bronchiolitis story. My name's Carmel, and what we're going to do is finish off the story from part 1 and start off with talking about prediction of non-invasive ventilation failure, and then talk about some of the other instruments and tools that we used and some other aspects of changes that we made in our unit that brought about the eventual success on our bronchiolitis children. Our final parameter that we worked on was the prediction of non-invasive failure, and the main reason why this is so important is that there's considerable evidence in adult non-invasive ventilation in adult ITU that delay in intubation in some patients leads to increased mortality, and this really is a significant concern, and there's particularly no reason why to think that this would not apply to children. And in addition, we were also very mindful that we are a high dependency care unit. Although we have access to pediatric anaesthetists, the act of escalating to mechanical ventilation requires some anticipation, some planning, because the anaesthetists are not immediately available. And also mindful that our intensive care unit is actually 2.5 hours drive away. So, bearing this in mind, we knew already that the more traditional ways of assessing the efficacy of NIV included, firstly, the reduction of a respiratory rate and heart rate and worker breathing between the first 2 to 6 hours. There's no clear definition of how much respiratory rate or heart rate should improve by, and certainly no significant guidance on precise timing. So you can immediately understand that one requires perhaps a bit of experience to judge the failure in terms of these parameters. Another sort of parameter is how much oxygen is being required, and certainly in children who need more than 60% oxygen, the kind of diktat is to give them pressure, and if you're going to give that pressure non-invasively, then I think arbitrarily, if they're needing more than 6 centimeters of water pressure and they're needing more than 60% oxygen, then that's another criteria by which we can deem a child to have failed their NIV. One of the main causes of NIV failure beyond the severity of the disease is being able to manage secretions and mucus plugging, and there are a group of patients who just appear to need mechanical ventilation in order to manage their secretions and what's called airway toilet, the clearance of mucus and secretions from the airway via an ET tube. Furthermore, we decided that if the child really wasn't improving within 48 hours, then we should escalate and consider escalating to mechanical ventilation and at the very least discuss with our PICU. So those were really the kind of mainstay, and in addition, we were fortunate enough to come across the possible use of SF ratio, which is the saturation to FiO2 ratio, and the reason that this could be a useful parameter theoretically is if there was enough correlation with partial pressure FiO2 ratio. So partial pressure of oxygen in kilopascals over FiO2, otherwise known as the PF ratio, is well recognized to be a predictor of NIV failure, and therefore if SF ratio could be shown to approximate sufficiently, then it's an alternative. And the other important aspect of using SF ratio, which I want to highlight, is that the saturations need to be at 97% or below, and this is pictorially represented in the graph on the bottom right hand side, which shows that there is a linear aspect to the oxygen dissociation curve between saturation in the y-axis and pressure on the x-axis, such that if you have saturation between 90 and 97, there's a reasonable linear correlation between those 2 points. So if we were going to use saturations, then they will correlate quite well with partial pressures. So let's start with the initial point that PF ratio in adult patients, so 5,800 plus patients, was shown to be an independent predictor of NIV failure if it was less than 146 after 1 hour of NIV treatment. In this same population, investigators went on to look at the possible correlation between PF ratio and SF ratio, and you can see the results in the graph on the bottom left, and I've drawn on in red on the x-axis the PF of 146, and you can see according to the straight line regression that they used, this would equate to almost an SF ratio of around 190. However, as you can see on that graph also, an SF ratio of 190 gives you patients with a PF ratio as low as 100. So not completely foolproof. Once this has been shown in adults, the next question clearly would be how does it work in children? And here's a study from the United States, PICUs, in almost 1,300 data sets over 380 patients, and they basically showed that a curve was a better fit for the data in terms of correlation, and that I've drawn on this graph just to help us again, a PF ratio of 146, and you can see that on the x-axis that correlates on the y-axis to an SF ratio of about 190. The dotted line represents the fact that on the PF side there would be considerable number of patients with higher SF ratio, and you can see again that there are a significant number of observations, so dots to the left hand side of the vertical red line, which shows that even with a SF ratio of 190, there will be a considerable number of patients whose FiO2 ratio would be lower than the cutoff. What this study was looking at, just to clarify, was the correlation of SF and PF ratio, and they looked at it at a PF value of 300 and a PF value of 200, and the reason they chose these was because PF value of 300 equates to a diagnosis of acute lung injury, whereas a PF value which is lower of 200 equates to a more severe condition called ARDS, acute respiratory distress syndrome. And in fact, with the lower SF ratios, the sensitivity became a bit less, although the specificity increased. So perhaps the possibility of using an SF ratio of 190 odd or so as a cutoff value may prove useful. So using that kind of cutoff of around 190, again, Spanish PICUs of 390 patients did an analysis, and 164 of those patients had bronchiolitis, and all of those patients were generally between the ages of 1 and 26 months. And they were looking to see how they could predict NIV failure. And in their analysis, they were able to come up with the statistic that if your SF ratio was more than 190, that this had a almost 96% chance that you would not fail NIV. So a negative predictive value if your SF ratio was 193 and above. We take that with a little pinch of salt because the numbers that failed between 1 and 6 hours was about 24, and what they weren't able to really show is whether SF ratio at 6 hours was particularly good at detecting failure between 6 and 24 hours. So potentially a very useful tool, but with a little bit of proviso in that it cannot be used on its own. It's not robust enough on its own. We have to still use the other parameters. So, we did adopt this, and I'm going to show. So, we want to see the use of the SF ratio in action. And so here's a good example. This is a ventilation chart that we commonly use in our high dependency care ward of, as you can see, a child weighing 11.6 kilograms and who is on BiPAP, the mode on the top row, and whose oxygen requirement, FiO2, ranges between 60 to almost 70 to almost 90% oxygen, and whose ventilation pressures started off at 12/6 at 6 p.m. and rapidly escalated to 14/6 and then finally to 16/8 at 11 p.m. And the bottom arrows show that it had physiotherapy input between 8 and 9 p.m. including normal saline and salbutamol combined nebulizer, and that appears to have improved the inspired tidal volume. But the FiO2 remains high, and as a result, the consultant, as noted by C, has seen them at 6 p.m. and the anaesthetist has been asked to come by, denoted by A, at around 7 p.m. and then the consultant has come back around 10 p.m. to see them. And if we look at the corresponding time for the next chart, and you can see that highlighted the pressure being increased to 16/8, but if we look at for the observations here, you can see at the top the respiration rate, and really you could argue that between 1700 and 2000 that there's not a lot of tachypnea to suggest that there's a concern. And at the same time you can see the heart rate between 120 and 140, again perhaps suggesting that there's not a lot of concern when we look at those parameters. But if we calculate the SF ratio, then we can see that actually they're really very low, much lower than the sort of 193 that we discussed earlier and the 200 that we've discussed in our guideline, and certainly below 175 for bilateral disease. And as you can see in that pink box, one of the other criteria is FiO2 of more than 60% for more than 4 hours, which is what appears to have followed in this patient. But as you can see with the first chest x-ray here, that child clearly has bilateral disease, and therefore anyone with an SF ratio of less than 175 is deemed to have failed, and perhaps we could have therefore spotted earlier than we actually did, and this child may be near 6 p.m. rather than midnight when the child was intubated. They needed intubating. And of course, in any hospital, it makes a big difference whether you do that at 6 p.m. and midnight, and the staffing levels, etc. And the x-ray on the right, post-intubation, x-ray with ET tube in the trachea, shows quite extensive collapse and consolidation of the right upper lobe, the right lower lobe, and the left lower lobe. And that also explains why the child's ventilation was so tricky, because the lungs really were very stiff. So we move on to another area of controversy, which is antibiotics. And on the face value of it, why would you choose to use antibiotics in what is known to be a primarily viral infection? So we asked ourselves that question, and we decided to do what you might call reverse engineering. So we looked at the endpoint and worked kind of backwards. So one of the endpoints, as shown here, is the detection that 40% of PICU bronchiolitis patients who have had a bronchoalveolar lavage are positive for bacteria, and that in half of those, i.e. 20%, the levels of bacteria are high, more than 10 to the 5, and have high white cells, which suggests that they have co-infection, whereas the other 20% have positive bacteria but don't have such high levels of white cells or numbers of bacteria. The other observation is that in PICU, if you only have a virus, you're likely to be ventilated for 4 days, but if you have bacteria as well, your duration of ventilation is going to be nearer 6 days. So a more severe disease, longer course. So that kind of asks the question, or begs the question, there clearly appear to be some patients who would benefit from antibiotic. How would we decide who? So most children who end up in intensive care, mechanically ventilated, will end up on antibiotic for treatment of their bronchiolitis. And we've taken a more pragmatic approach that maybe we can prevent NIV failure if we treat the more severe patients who are at high risk of co-infection. So we've arbitrarily decided that any patient who has oxygen requirement of more than 50% for more than 4 hours on respiratory support should receive antibiotic. I'm just going to briefly talk about weaning. It's a bit difficult to go into in detail in a presentation like this, but basically we've come up with the idea that we would try weaning after 48 hours of respiratory support if the oxygen requirement is moderate, and certainly if the work of breathing is mild to moderate. And that if you're on high flow, we could go quite rapidly, and we've kind of done PDSA cycles to show that rather than going down by 1 litre per minute, or 2 litres per minute, or 3 litres per minute, gradually every 4 to 6 hours, and that would take usually a day to wean, we were quickly able to show that stepping down from 3 litres per kilo per minute to 2 litres per kilo per minute every 4 to 6 hours, and then down to 1 litre per kilo per minute, was perfectly safe. And a similar approach to the use of CPAP, but we had to be much more individualized weaning BiPAP. And we've become more adept at weaning from BiPAP to high flow and then off. And the weaning is invariably either consultant or nurse-led. Next comes the topic of early discharge. And so after having sedated, treated optimally, and hopefully got them better, we need to discharge our patients. And there's this particularly clever double-blind randomized controlled trial called the BIDS trial, which is the Bronchiolitis Early Discharge trial. And it's an extremely well-designed study. So the study was to look at whether the UK sign guideline recommendation for oxygen saturation being above or equal to 94% before patients with bronchiolitis are discharged versus the American Academy of Pediatrics and WHO guidelines, which had recommended that it was safe to discharge patients recovering from bronchiolitis with minimal worker breathing if their SATs are 90 or above. So, as we can see here in the right-hand table, they were able to recruit 308 patients for the standard group and 307 patients for the modified group. And for the modified group, what they did was to enable them to maintain a double-blind approach, so that neither the clinicians nor the parents knew that what their saturations really were. What they did was they rigged the pulse oximeters to read 4 points above what they were actually reading. So if the actual saturations were 90%, the machine would read 94%, and so the clinicians were making decisions based on those readings, which is a really clever thing to do, I think. And as you can see here, looking at all of those parameters, there's no difference between either of the groups. And in terms of outcomes, so one of the first ones they looked at was time to discharge. And in the top table, in the red highlighted box, you'll see that the time that they were designated as fit to discharge in the modified group averaged at 30 hours compared to 44 hours for the standard group. And that, very interestingly, the time to no further oxygen was significantly lower, so 5.7 hours compared to 27.6 hours if you were using the lower SATs target compared to the higher SATs. And we can see, in terms of looking at the graph on the bottom left-hand side, that the left y-axis shows the proportion of patients who weren't yet fit for discharge, and the time along the x-axis, and where the red arrow is about 3 days, 72 hours. And you can see on the y-axis that in the blue line, those who are on the modified group and were being given oxygen had almost 21-22% of the children not yet fit for discharge, compared to almost 40% of the children not yet fit for discharge with the higher saturation group. Very interesting finding, and definitely, would make one think, is this something worth pursuing? Are there benefits? So, having understood the potential benefits, we also always have to double check, are there any downsides? Are there any adverse events or safety outcomes that need to be analysed? And very interestingly, we can see in the top part of the table that in terms of adverse events, there's no difference between the two groups. And as we look at safety outcomes, there's no difference in mortality, the episodes of high dependency care, and within the larger red box, in the top row of that box, you can see that the readmission to hospital within 7 days is equivalent. So no real adverse outcomes. What particularly also interested me when I looked at this was that when we look at readmission to hospital within 28 days, there's perhaps a trend towards higher number in the standard group. And what really intrigued me was particularly the reattendance to healthcare within 14 days at 29% in the standard group and 27% in the modified group. Not that the fact that there isn't a difference, because that just underlines that the so-called early discharge criteria are perfectly safe. But in a kind of different way of looking at things, how large that number is, the number of babies that attend or reattend healthcare within 2 weeks of discharge from hospital with bronchiolitis, is quite a staggering number. And that now makes me think that we should be paying a bit more attention to how we discharge our patients and how we prepare them for discharge. So we'd, in our hospital, already been working on how to prepare them for discharge after weaning, because we do weaning quite quickly. But I think this just highlights that we also need to pay more emphasis and attention on how we prepare them for life at home to try and reduce healthcare attendance after discharge. So I hope you enjoyed a little run through of some of the areas that we'd identified in our kind of clinical pathway to work on, and that this has been interesting as well as useful. So we're now going to move on to some of the other areas that particularly were useful and important beyond just working on these clinical areas. In particular, I want to start with focusing on the safety of the bronchiolitis patients. This is important to maintain that, because as a whole unit, we're pushing several boundaries of practice. As you can see, 16 different areas, and we had to make sure we weren't really neglecting other patients in our drive to focus on this particular group. So, as luck again would have it, we came across a ward round checklist, which we adapted. A year later, we introduced Huddles, and this is directly from the work done in the first round of units and hospitals that took on the quality improvement of introducing Huddles as a safe measure, as a situational awareness for everyone. That's what SAFE stands for. Measure to improve psychological safety and improve the safety of care on a ward. And we also had a go at standardising processes where possible. And that kind of approach you'll see and hear about a little bit more in the patient safety discussion and talk later on in the course. So it's, we provided and managed to design a care pathway to reflect this. So one of the first things that we introduced was a ward round checklist, and here's our one that we use on Pediatric HDU, and it's what's called a considerative checklist. So it's a prompt for considering certain tasks, thinking patterns and behaviours to do during the ward round. And what I've highlighted here are some of the, in red, are some of the points that I particularly want to emphasise. So the first one is at the top, the fact that we take parental concerns very seriously, and this is a prompt to elicit them and to document them, and to particularly also document what we're going to do about them. Of course, we have to ensure that we're documenting sedation scores and they've been looked at carefully. Going down the list, you'll see considering whether physio input is going to be helpful. And one of the things that we've added, which isn't showing on this particular version, is that we've added in a question, what matters to you? So really to try and get a more personal approach to the family and trying to understand better what they need, what they want, and what we can do to help with that. And at the bottom you'll see that there's a pause, and this is really to trigger people to discuss what they're thinking, to have a shared mental model so that we're trying to really think from the same hymn sheet, and to make sure that everyone's understanding is at a similar level and that there are no issues or concerns that have not yet been discussed. So our view is that if we fulfill all these elements of a ward round for every single patient, then we think we're going to be providing a really high quality, excellent and personalised care to our families, just in the way that we want. About a year or so after we introduced the ward round checklist, we became aware of Huddles, which was a Royal College of Child Health and Pediatric initiative, through SAFE, the Situational Awareness for Everyone programme, and it was piloted in about 11 different units around the UK, and their experiences were shared at the Royal College of Child Health annual spring meeting. And from that we took away the fact that Huddles appeared to have significant improvements for staff in terms of their safety approaches, improving the safety culture, improving throughput for patients, perhaps increasing and facilitating early discharges, reducing harm, etc. So we've created our own, and you can see here that first and foremost patient safety is of paramount importance, and eliciting concerns from all the various groups of people who are on the unit on a regular basis, so nurses, doctors, parents, discussing if high-risk interventions are being planned for any of the patients, being aware of similar names for both patients and staff, and then moving on to see what's happened in the previous 24 hours regarding 6 main areas of safety problems, so medications, cannulas, infection controls, catheters, skin tissue vulnerability and safeguarding. And then moving on to talk about staffing levels and how they might impact for us. So, together with what's been planned, which patients might need physiotherapy, speech and language therapist, etc., which families might require additional discussion, and to remind everybody that the FFT, the Friends and Family Test responses to be given out for all the patients who are being discharged, to discuss what might be required to facilitate patients to get their discharges done. And then lastly, the order of the ward round, written on the whiteboard, as well as the nursing breaks and what time they're going to be. And so really trying to make the breaks a bit around the ward round order and vice versa. And so that led to an improvement of the nurse being present on the ward round with their patient, increased from 70 to 95% as a result of a simple thing like writing down the breaks on the board. Here's a picture of the first page of our care pathway that we created, with all the members of the staff, so nurses, doctors, physiotherapists, the play team, medical students, and we tried to include parents. I think that's work still in progress, and we need to probably do something extra around that. So in particular, you can see on the top right hand corner there's meant to be information that's given to the family, but we haven't yet created the type of information really that we would like, so that's work in progress. And you can see from the left-hand side that once the diagnosis of bronchiolitis has been made and a decision has been made for respiratory support, there are prompts for staff to prescribe sedation on the PRN side, on the right-hand side, and the down arrows suggesting that hypertonic saline nebulizers are prescribed and what feed and fluid regimen to do according to respiratory rate. And once you're on HDU, on the bottom in the dark blue squares, making sure that we look at the body position and decide whether antibiotics may be needed. Moving on to the next page, which is on high flow nasal cannula. At the top there's a suggestion of what kind of patient is likely to benefit. We tend to view high flow as almost CPAP light, and so patients with respiratory rates greater than 60 or FiO2 greater than 40 or severe worker breathing tend to get either 3 litres per kilo straight away or CPAP, but for the others we would start with usually around 1 litre per kilo and build it up, and if we build it up gradually we find that we don't need so much sedation. So there's prompts here to look at alternative sources of pacification and reducing distress other than sedation. And also you can see in the bottom, in the sort of weirdly browny orange squares, about what to do regarding weaning. So having put all this together and hopefully made a success of it and demonstrated that, we also felt that we had an obligation to share our understanding and knowledge. And so here on the bottom left-hand side of this slide you can see the advertisement, the poster advertising the United Kingdom's first European Society of Pediatric and Neonatal Intensive Care, the ESPNIC course for NIV in neonates and children, and we hosted that in Brighton. So that kind of made us one of the first sort of people to embrace this technological innovation enthusiastically, and the people who attended on this course came from various parts of the United Kingdom. So that included the team from Stoke, who the following year went on to host another course in their institution, and the team from King's College, who also attended our course, followed the same. And so we'd like to think that we're at the beginning of hopefully getting people to move from just being pragmatists in the early majority to also making this technological advance being adapted much more widely throughout the United Kingdom, which I think would help considerably in reducing the number of PIC admissions with acute respiratory failure in the children. So I want to show you these two graphs, which include the latest cohort of patients that we've analysed. So that includes the winter season, October 2016 to March 2017. And the right-hand graph shows you that our numbers of patients that we treat in our HDU, ranges around between 85 and almost 120 for the last 3 or 4 years. And that the red line at the bottom shows that our percentage of intubation in bronchiolitis remains quite low, and really something that we should be proud of. The left-hand graph also shows the latest cohort, and the dark blue line shows that our use of Optiflow remains high compared to a dramatic reduction as seen in the light blue line in the use of CPAP, and that we're maintaining that over the last 3 seasons. Our use of BiPAP remains fairly steady, having really kind of introduced it back in almost 2011-12, we see just about double-figure patients under the age of 2. And they're probably children who otherwise would have been intubated because they would have failed CPAP. So, in broader terms, you could say that the lessons that we've learned include, as I've already alluded to before, that although we've talked about the story looking more like a linear straight line as the road to success, and is easily mapped and maybe straightforward in some ways, it was actually far from that. There were many points at which, obviously we questioned ourselves, we were wondering about the validity of what we were doing, making a few errors as we went along, having to think about, is what we're doing safe? And fortunately the timing was such that we got through it, particularly with the advent of the ward round checklist and the Huddles, which all helped along the way. So in broader terms, what I think we've really done is to combine primarily a whole systems approach and also people. So taking people and using their skill sets and getting it out of them and carrying everyone along with us was really important. So of course that involved looking at the entire clinical pathway, considering our thinking patterns along marginal gains theory, and as I've already mentioned, what's captured by the idea of black box thinking. And so we were brave enough to try, adapting and adopting solutions that we learned from both what went well as as failures, and we improved our safety using human factor theory. So the Huddles, as I've said, and in particular we were focused on looking at unintended consequences, deciding that human performance would be improved by use of checklists, and at the same time we were developing our team dynamics, deciding how we're going to support our staff in learning, what we would like the role modelling to kind of look like, and how we would try and get everyone to realise their individual potential. So that involved creating a flat hierarchy, using perhaps appreciative inquiry techniques, and all of this, kind of worked together. And it required, a particular style of leadership to make it work. And you need it all because, healthcare is kind of complex and messy. But as a result of our endeavours, what was thought to be impossible was made in the end. And in part, we had to follow the courage of our conviction that NIV had something to offer. That was based on the data that we had seen from our study and travel to Spain. We had to always remain humble that even though we'd acquired some expertise, that we still needed to keep testing it on a very regular basis at all times, and learn from our mistakes and then adapt really quickly. And all along we were fortunate enough to have medical students who were willing to help us create what I think is probably Western Europe's largest database of bronchiolitis patients. And if anyone wants to come and use that database for any kind of analysis, you're incredibly welcome. So these photographs here show on the bottom right hand corner the teamwork that's required when we're stabilizing a patient who's needed intubation. The personalized approach on the top right hand corner, so the architects who designed our building also, just like us, and took inspiration from us, I think, in designing a child-friendly room so that window at the bottom is at the eye level of a child lying in bed, so they can see the sea and look out. And none of this would have been possible if it hadn't also been for charity funding from our Rocking Horse charity, which donated almost £30,000 worth of equipment in the end for us to be able to do what we do. And as always, with such an endeavour that we've managed to achieve here at the Alex in our HDU, that there are various people both inside and outside of the unit, various organisations that are involved, and I really do need to highlight in thanking them. So first and foremost, the two characters that you see in the bottom right hand corner. On the very end of the right hand corner is Professor Marty Pons with his beard and glasses, and his colleague Alberto Medina on the left, and they're both incredible, fantastic teachers who have really pushed the boundaries of the use of NIV and have taught us so much, and in such a wonderful and humble way. And for us, a key player in the middle, you can see there, Janet Lee, our practice educator, shaking a rattle in true fashion, being a patient advocate, always reminding us about the importance of looking at things from families and patients' points of view. Some of the rest of the team on the bottom left-hand corner. And then you can see in the middle on the left, one of our medical students, Poppy, presenting her work on sedation at the European Society of Pediatric and Neonatal Intensive Care in 2017. And on the right-hand side, Rania Derrick, who presented her poster on high flow and our experience of using 3 litres per kilo per minute. And if you want to know more about non-invasive ventilation, then you can see on the top right-hand corner that there's a picture of a book. It's a reference book on pediatric non-invasive ventilation. So you've seen there the Spanish version, there's an English translation, which is around £50 or so, and a fantastic reference if anyone wants to look at how to do non-invasive ventilation in children. So with that, I'm going to finish, and I'm going to thank you for your time and patience. I hope you enjoyed it, and I look forward to seeing you. Bye for now.